one of my DNB student here, Dr. Shashank. If I just ask you one question, the Merrill which we are doing today, Merrill knee which we saw today, is it a single radius or multi-radii? Any idea? No. So that is what we want to speak about, because we are talking about Zimmer Kia, we are doing Zimmer, we are doing Stryker, we are doing, but none of us, quite less of us have got knowledge what is multiple radii. And for this I had requested, and Dr. Abhishek Das grandly agreed that he should speak on, does single radius or multi-radii knee affect, it really matters. I mean, most of us say डेप्यू का नहीं किया, जिमर का किया, मैक्स का नहीं किया, स्ट्राइकर का नहीं किया, बट करना क्या है और what does it matter? Single radii, multi radii, what is the concept? And that's why the theme is let's simplify joint replacements. So I welcome Dr. Abhishek sir. Thank you.
Good afternoon, everybody. I hope my talk will not put you into post-lunch slumber. I'll try to keep it brief. First of all, I'd like to take this opportunity to thank Dr. Ashish, good friend of mine, and the whole AMC team for this fabulous course, which I thoroughly enjoy coming to, and I hope you all are enjoying as well. So let's see what is this concept of single radius, multiple radius, gradius, MR knee, and things like that. So when we talk about single radius and multi-radius knee, it is mainly regarding the femoral component of the knee. And regarding this, let's understand a little bit basics about the native knee kinematics. So the question is, sagittal femoral diameter affects knee kinematics. This is very well understood, but does it affect the outcome? That is what we all are interested in, and let's see what happens to it. So I tried to pull out a little bit of literature. So a meta-analysis of the outcome of single radius knee versus multiple radius knee, and this was done in the year 2016. To put things into perspective, the first knee which was designed around 1971, the popular one, was a multiple radius knee, and then due to few of its theoretical pitfalls, I would say, its successors came like single radius, gradient knee, or gradius knee, or the medial pivot knee. So it initially showed that the single radius knee has lower range of motion as compared to multiple radius knee, but actually if we look at other functional scores or the actual clinical outcome score, there was no difference between the two. So this was 2016. So how does the sagittal femoral diameter of the knee affects the knee kinematics? So if you look at the femoral condyle, the medial and the lateral femoral condyle, there is a bit of difference. The medial is a bit smaller, bit more congruent or conformant with the tibia, and the lateral one is slightly bigger, and it actually allows the posterior roll back along with the PCL. If you look at it in a bit more detail, there is an anterior and posterior horn facet, there is extension and flexion facet. These are a bit didactic details. Does it affect the range of motion? So if we look a little bit more detail, so we can divide the knee range of motion into three arcs. The extension arc, where you have the screw home mechanism. Then there is the functional arc, 30 to 120 degree, where the radius slightly shifts backward or posteriorly. And then there is the passive flexion, that is 120 degree beyond, where there is the posterior rollback. Now, according to femoral sagittal design, the knees have been classified as single radius, multiple radius, gradually reducing radius knee or the gradius knee, and the medial pivot. Let's look a little bit of these one at a time in a little bit detail. So if we look at single radius knee, the standard one or the commonest one which comes to our mind is the triathlon knee, which was the pioneer in the single radius design. And then there are others like the Zimmer Vanguard and things like that. So why is it called a single radius? It is called single radius because if we look at the radius of the knee, then from the front to the back, you actually have one single center there. So the center doesn't slide or shift backward, and therefore the radius remains constant. This is based on a very big assumption that the flexion extension axis is centered on the transepicondylar axis, and the superficial MCL remains isometric throughout the knee range of movement. So once you are examining the patient's pre-op, it is imperative to examine the MCL function or to assess for the MCL laxity preoperatively. And if you're planning for a single radius design knee, then it is very important to protect your MCL, even in other cases as well, but it is very, very important in these kind of knees. So what are the theoretical advantages? The theoretical advantages are that the quadriceps effort is lower in these knees, and there is a lower possibility of mid-flexion instability because the radius doesn't abruptly shift backward as in a J-shaped design, which is the conventional multiple radius knee. So let's look at a study. So I've just chosen one study, which is a 10-year outcome of the survival of the single radius knee, which is triathlon, and it has shown excellent survival rate comparable to others at this point, which is 97.9% survival and a patient satisfaction rate of 88%. Now coming to multiple radius knee, why is it called multiple radius, or at least two radius? Is that the radius, the center shifts backward, so it is based on the thought that the distal femur is J-shaped design, and it has got larger anterior diameter, which reduces posteriorly and thereby increases the degree of freedom, thereby allowing more flexion. This is due to its the fact that it helps in the femoral rollback and rotation, and therefore when this transition takes place, that is the shift of the radius takes place from the extension to the flexion, that is posteriorly, at some point there is a concern that the transition may happen abruptly, leading to mid-flexion instability. Now this is a theoretical concern, I would say, and due to this concern, a lot of other knees were designed. Now what are the commonest knees that we use, which have multiple radii? These are PFC Sigma, my favorite, of Depus Synthes, the next gen Zimmer Biomet, and there are others like Genesis knees. They are all multiple radii design. So this is a very good study if you want to look at the survival of the knee replacements, which was published in Lancet. And if you look at it, so till 10 years you have the data for the single radius knee, but if you start dishing out the data for 15 years, 20 years, 25 year survival, there's only one which stands out, and that is the multiple radius knee. And the PFC Sigma, it has got a survival rate of almost 90% at 20 years, and the next gen almost 96%. If you come to 25 years, this is the Finnish National Joint Registry. The PFC Sigma has got a survival of almost 86%. This is quite a lot, and other prosthesis will really have to work hard to reach this point. Now, coming to gradually reducing radius knee or gradius knee. So the pioneer was the attuned knee system of the Depus Synthes, and it is one variety of multiple radius knee, I would say. Now, why was this design done? This was done so that the posterior diameter, the radius gradually reduces rather than an abrupt radius change, as was the case in the J-shaped design. This was designed so that there is a smooth transition from extension to flexion, and thereby less likelihood to cause mid-flexion instability. Now the early results have been promising. We have to look whether this initial or the theoretical advantage, does it really translate into any clinical value, or the clinical outcomes, are they equally good? So I just came across early to midterm results of the attuned knee, and they say that the results are comparable, and early results show that they are promising, and the satisfaction is slightly higher with the attuned knee in the early 5 years. But if you look at the data very carefully, then Depus Synthes had to actually revise their tibial component because of radiological evidence of loosening at 2 years. So the current attuned knee which we have is sort of a second generation tibial component, and they do not seem to have the same problems as the initial ones. No talk on knee replacement can be complete without the National Joint Registry of the England and Wales. This is the 2022 results. If you look at it, again, my favorite one, the numbers are declining and has been overtaken by the single radius knee, that is the triathlon. But again, the other reports, that is the clinical outcomes and things like that, there's no real difference. So to summarize, there's another meta-analysis which came out in 2020 comparing the functional outcome of single radius knee versus multiple radius femoral component knee. And the results are that inclusive of all knee function, the clinical outcome, there's no difference between the two. The patient satisfaction rates are equally good, and actually there's no real difference in the real world. And just the take-home message would be, in my opinion, all the concepts are good as long as the operating surgeon understands these concepts and performs the surgery based on those design philosophy. Both the multiple and single radii have excellent long-term results. Only the radius knee, it had initial glitches, and so you should, advise a little bit of caution when you're doing it. These are some of the knees that I have done, nothing fancy about it. With this, I'll end my talk and I'll take any questions if you have.
Dr. Shashank, any questions? Okay, got it. You need to sit with sir and question, ask faculties whatever doubts you have, any of the PG especially. I'm not pointing you, but it is mandate to keep asking because you're in a congenial environment. Now I would like to invite. Yes, sir. Sorry, sir.
No problem. So Steve Howell sometimes talks about a radius of curvature relative to 3 different compartments of the knee.
Yeah.
The anterior, medial, and lateral, all having a different radius. Yeah. And it kind of flies in the face of this idea that it has to be a single or a multi. Yeah. But it's actually 3 separate circles, and the patella is the whole condyle, but really only the back half of each condyle is important to tibial function because the tibia never touches the front half of the condyle. Does that make sense to you?
Yeah, I totally agree. And in fact, one of the pioneer designs where it was a dual condyle knee replacement, preserving both the ACL and the PCL. And yeah, good fellow knee. And that has one of the best clinical results, but it was so complex that it was difficult to replicate his outcome. I think knee is such a complex joint that theoretically we can talk a lot of things, and I take your point on board, but I don't think I have either the lab experience or the practical experience to answer your question. But I think it would make sense if the radius knee was translated to one where you have a gradually changing radius for medial as well as lateral condyle, and to adjust to the patellofemoral compartment as well. They have tried to address the patellofemoral compartment in this one with more conforming patella, but in India, most of the surgeons do not resurface the patella. That is another challenge. What if you try to preserve the native patella and you do a total knee replacement without patella resurfacing? Does it still work? That's another question to answer. What are your thoughts, sir?
I wish you would teach me how to do no patellas. I tried from my mentor Leo Whitesides to not do patellas, and fully 10 or 20% came back and didn't like my knee. And I live in a small town in the USA, so if you're at the university, you can write up your 200 failures and become famous for it, or worse, if I have 3 failures, everybody in the world knows about it, so I can't do that. The 20% failure rate on a patella would wipe me out. So my bias would be it's a very quick and simple operation. The one person I don't like to do patella resurfacings on are obese women. because they break doing daily activities. It's incredible. That's been my experience. So I don't do that. Short of that, I pretty much resurface everything, and I don't know how you get away with it, but I'm going to pick your mind after this, and you're going to teach me how to do it better.
So with this, my case is ready at the theatre, so I'll ask next speaker. May I invite Dr. Ramakant sir? He's from Ruben Hospital. And